Hello, I'm Stanley Liu, and once again, very honored for the invitation to the SEC. I do apologize that I cannot make it in person this time, but I'm very thankful that Jerry still, has helped to coordinate for me to deliver this via Zoom. My topic, from the nose to tongue base, beyond DISE for Inspire Candidacy. And really, what the point of this talk is, um, it's pretty straightforward now. We know what are the basic, eligibility criteria for upper airway stimulation. But what are some of the considerations that we have found to make upper airway stimulation more effective? Okay, and so that's really the premise of this talk. This is me in a nutshell, or me in the QR code, if you will. I always very much appreciate your feedback and continued collaboration. Airway is always a collaborative space, and that's why it's been so wonderful. Speaking of wonderful, this is Jerry's team. I sent patients to him. In this case, I sent a whole family. As you know, it can still be very, very difficult to get good sleep studies, done rigorously, scored rigorously. And I just want to see what all the fuss is out in Houston. So thank you again, Jerry. It was wonderful to see your team. And yes, Jerry and I have a shared lineage with wonderful mentors like this. Always love this quote. As late as 1970, the practice of medicine ended when the patient fell asleep. And precisely meetings like this SEC, symposium, really allows us to make that progress in medicine when the patient is sleeping. And of course, for me, coming full circle at one point as an undergrad, being introduced to sleep and dreams, and then going back to teach. Granted, it is very difficult to teach undergraduates to keep them entertained, but wonderful journey nevertheless. So we'll begin to talk about hypoglossal nerve stimulation. This is I joke about this. Used to be the closest I would get to a clubbing environment when I was back or in the OR, let's say. Okay, so the eligibility indications for Inspire has evolved, of course, quite a lot. And but this is where we are today. So the range of AHI is quite liberal. The BMI range is very, very liberal. And ruling out a quarter of central apneas, etc. And the very well-known no complete concentric collapse at the velum has always been a key selection criteria. And of course, that requires sleep endoscopy. So Inspire would be what we would say unilateral, and usually we implant it on the right side of the neck with the battery usually coming down to the right side of the chest. It has always had a sensing lead until Inspire 5, or the very current iteration. And so classically, it's a three-piece component where you have a sensing lead, you have a stimulation lead, and they connect to the implantable battery. Right. And even that battery has decreased in size, and everything's become, MRI compatible really over a very short amount, time period. And it's quite impressive. We are blessed, of course, now with another system in comparison. There really is a third system as well, but these are the two FDA approved as of now, and this is the Genio system from Nyxoah. Difference being that, let's see, let me go to the summary here. So it's bilateral, and meaning it targets both sides, right? Both hypoglossal nerves, and it targets it at what we call the distal, which is really all the way at the submental chin area. So it's really a central paddle there, but then, in effect, it becomes a bilateral stimulation. No sensing leads to go from the start, no implanted battery. This is an external activation unit that patients wear under the chin during sleep. So fundamentally, it is quite a different design. But I think more importantly, it's different in that it's targeting way out at the chin area where you have all the little distal branches of the hypoglossal nerve versus Inspire, which is a lot more proximal, and we'll look at that in slightly more detail. Okay, so this is, and you have this in your PDF handouts. This is from the BLAST OSA trial for the Genio system. You can see that it achieves close to the classic definition of surgical success, the Scher's criteria for surgical success. A little bit more limited on the Epworth Sleepiness Scale. And we'll come back to that with a later study that's quite interesting with regards to patient-reported outcome measures. The DREAM pivotal trial is the bigger trial, and this was the basis for the FDA approval in the US. And the results are certainly very robust. And so just a very quick head-to-head comparison. Inspire's unilateral. The Genio system is bilateral. The electrode, you have a cuff around the medial branch of the hypoglossal nerve for Inspire versus a paddle at the chin. And while classically there has been a sensing lead, there is no more with Inspire 5. No sensing lead from the get-go with Genio. We talked about the battery. We'll look more closely at the incisions. And there's technically not a true complete concentric collapse exclusion with Genio. And so and I do expect some of these things to shift. I bet, perhaps the BMI limit or the AHI limit may change as time goes on. Okay. So these are our two FDA-approved devices with fairly comparable efficacy. And again, selection criteria being important. And that's one of the things we're going to talk about today is, well, fine, but what are some of the things from the nose to the tongue base? What factors into, let's say, improving the outcome of upper airway stimulation? Okay. So this is the classic, again, the classic Inspire, the very original. I think when I wrote this chapter now, it already evolved from the sensing lead that requires a third incision down here by the intercostals to basically two incision approach, and the sensing lead, it just sits, underneath the battery. Okay. But the most important thing to remember is, and you'll see there what I'm isolating are the medial branches of the hypoglossal nerve. And you'll see there's like a breaking point, right? So the other ones are the distal branches. And the concept is that those branches activate the retrusor muscles of the tongue. And we certainly don't want to include them during our surgery. And as you know, we can test for this with the NIMS probes. And so it's unusual for someone to grab a retrusor branch by accident in the way these surgeries are performed. It kind of looks like this. So the tongue curls, it pulls forward a bit, the tongue base pulls forward. And of course, in an ideal case, it pulls everybody forward, including the epiglottis. The visual you see with the tongue, of course, is with the patient awake, mouth open. I just wanted to, show you what that tongue activation looks like. And then these other two images are coming by way of sleep endoscopy. Okay. Now, historically, it's really kind of cool, right? Because again, 1979 is really not that long ago. And this is a slide from my mentor, Nelson Powell, who described how, the original sleep surgery protocol at Stanford, the Riley-Powell protocol came about. And they were both dentists who then had medical and ENT training. And then they met up again at Stanford during ENT. And then they met up with Christian Guilleminault, I guess, in an era where weight loss and trig were the only options. I mean, this is even before CPAP and everything else, right? So, I always find it really fascinating. You'd have a meeting like the SEC where you talk about all these different things that we have, options we have for patients, and it really wasn't quite so. So in their era, in this era, right, the original Riley Powell approach, right, phase one, phase two, phase one being, the uvular palatal flap, and for the hypopharynx, they like the Genio glossus advancement. 40% of patients who don't respond to it would then march onward to maxillomandibular osteotomy slash advancement. Memorable moment. This was then my first activation at Stanford, and CG was very interested to see what's going on. And these were all the sleep medicine fellows at the time. A lot of them became faculty, and we were titrating our first patient. Um, I guess we had fairly large exam rooms to put folks in there. But essentially, here's a first very interesting case where we made one of the first additions of upper airway stimulation to the original protocol. So we had a patient who had GGA and MMA at Stanford with Bob Riley and Nelson Powell back in 2009 at age 19. I guess at a very good result, AHI of 4.5. Relapsed fairly quickly by age 60. Had really relapsed already to moderate sleep apnea. And, at that time, I guess he did MMA first. So they did a little nasal surgery, uvular palatal flap. Bob liked tongue-based radio frequency. Didn't really do very much for the patient. Comes back and sees us. And that time I was there. And so at 2016, the patient at age 65, and he became our first and likely the world's first MMA to upper airway stimulation candidate. When we did the sleep endoscopy, we were very happy to find that the velum and the lateral pharyngeal wall was rock stable. And that was the thing that I added to the MMA literature, which is that when the MMA works, okay, let's just say you design the movements and it happened to be perfect for the patient, it is in the stabilization of the velum and lateral pharyngeal wall that really dictates the success. But then, of course, the response of the tongue can be quite variable. So what we did then was to put our first, and this is the old school 3-incision, big battery approach, but the patient had a great outcome. And I invited Bob to come and check out that case and we really, then brought upper airway stimulation into our overall protocol. So then with that kind of a case, then we started thinking, well, then these combo cases could work out pretty well, right? So we had a 65-year-old man, BMI is 29, and the baseline AHI is 145. So certainly outside of the range for Inspire alone, but you don't want to do a very big MMA for a patient of his age. And so you can see here, I did a relatively conservative MMA. We were able to bring his AHI down significantly, repeated the DISE, no concentric collapse, and then we followed. So in this time, it wasn't waiting for relapse, or I guess, we still have a ways to go with an AHI of 28. So then we proceeded. It was staged. After MMA for some time, we went right forward to upper airway stimulation. And it was really cool because the patient was highly compliant on his hypoglossal nerve stim, and you can see his settings. The last we checked, hanging out with an amplitude of 2.2 volts. When we talk about rates and pulse width, it's just about where along the electrode we activate more or less. You can see there are 3 electrodes on that cuff, and he did very, very well. Okay, so that's why when we updated the algorithm, as I mentioned, of course, if the patient has existing skeletal problem, what we call dental facial deformity, the folks that you would do orthognathics, let's say, traditionally anyway, of course, you want to do it with the airway in mind, or patients with concentric plus lateral pharyngeal wall collapse, we would recommend, patient makes the decision, but we would recommend to go with the MMA first and skipping over these guys. Of course, everything goes on the continuum, so you can also start with the MMA and then go backwards, of course, or whichever way you want to call it, okay? So that fit in for us really, really well. And that algorithm has been published in a lot of different disciplines. A useful one for our C medicine colleagues may be the one in Murray and Adele's chapter, where we then fused more elegantly the surgical algorithm with the CPAP titration, the PAP algorithm together. Okay, so it's a quick, maybe for your trainees, fellows, could be a nice quick read. All right, so now, you know, if complete concentric collapse of the velum is an exclusion criteria, right? It may make sense that we could do a good palatopharyngoplasty, and reverse that. And how reversible is it, and what does it look like? It's not a fancy study at all. We really just looked at 12 patients who underwent palate surgery, soft palate surgery, to resolve complete concentric collapse, and look at their post results. And in a brief word about the technique, the classic UPPP, vitreopalaryngoplasty, is kind of ablative in nature, I want to say. So you're excising the uvula, you are separating muscles along the lateral pharyngeal wall, your paloglossus, palopharynges, and then you're suturing it all over the place. I mean, you're really reconstructing something that, really most contemporary U triple Ps are not like that. Most contemporary triple Ps are, preserving muscle, and obviously that preserves, velopharyngeal function, but really the upper airway is muscle, right? You don't want to excise muscle and create those issues. So really, with our preservation of pharyngoplasty, we just try to emphasize to really preserve all the tissue. The idea is to suture a more unstable muscle to a more stable muscle. So, the palatopharynges, towards the paloglossus, anchored, up at anchored, say, at the levator, and also the tensor villi palatini. Let me just show you the video here, right? It's just three sutures, on each side. And you can see that this is before we tie it down. So this is where we pass the sutures through the muscles. And if we're in a good spot, right, we're expecting dilation and advancement of the soft palate once we're done suturing. Okay, so it's almost like the modern day facelift, right? You're not excising tissue. What you're doing is you're anchoring, and you're anchoring them to more stable muscle. So, well, at least this cohort all converted, right? Very reliably. Certainly not enough to say, oh, we have addressed sleep apnea entirely. No, but we have changed the configuration of the collapse, and then now we can march them along to hypoglossal nerve stimulation. And of course, we the field knows this is kind of where it goes. You would say, well, then why not just do the palate and the hypoglossal at the same time? And I believe some people do that. But with sleep procedures, my view is that it's still better to stage things. You could patients respond so differently sometimes to every procedure. You may or may not need to go all the way or exhaust all of your options, all of which in one go. Okay, so the complete concentric collapse is modifiable, and we can sequence it, and we'll come back to that in a moment. Okay, so that's up at the soft palate. We also had a very interesting case that we shared as a case report, and this is a collaboration with my good friend Dr. Karuna Dewan, who was a laryngologist with me at Stanford at the time, and now she's down at LSU. And we had a tough patient, and not tough. He wasn't tough, it was a great patient. But where we were stuck was we had a trouble titrating the hypoglossal nerve stim to effect, meaning originally get it to work, right? So he goes to sleep lab, they titrate it, and to get it to work properly to open up the airway, it required 4 volts. Now, maybe some people can tolerate it, but he couldn't. And 4 volts is way too activating, and he can't sleep with that. So well, I'll just show you. We have images from it. Actually, let me go to the next slide. It might be more clear. But the idea is this. It's basically these are not very impressive lingual tonsils per se. I mean, look, they technically even sit at the level or underneath the epiglottis. Um, but what we saw during sleep endoscopy was that with lower voltages, when we activate and the tongue pulls forward, it won't pull forward too much, but then the lingual tonsil was always somewhat obstructing the airway. So with Karuna's help and there's nothing like laser reduction of lingual tonsils because it really is the least painful for the patient. Patient recovers quickly. So that is in comparison to your coblation and even more painful, your transoral robotic surgery tours. Okay. And again, we just wanted to take that lingual tonsils down somewhat so that we can use a lower voltage for the hypoglossal nerve stimulator and make it work for the patient, which we did. Okay, so just these little modifiable things, because really when the patients aren't happy with it and they're a little bit frustrated, sometimes they're so annoying they want to remove the upper airway stimulator, and sometimes it's just going to take some troubleshooting, but then you'll see that there is quite a bit of troubleshooting. And if you do hypoglossal nerve stim, ideally you have a great understanding and you also do all these other parts of sleep surgery, or you're aware to collaborate with others so that you give patients the best outcome. Okay. So that's just again, so down to the tongue base, a little bit of modification there could go a long way. All right. So then I think this one is an important study, and that is, okay, so what happens then if you have a bunch of patients and they're initially ineligible, let's just because their AHI is too high. Now, Inspire expanded it to 100, AHI of 100, so it's less of a point. But when we did the study, we were looking at patients where this was when the criteria, the AHI limit was 65. So then what about patients with an AHI of above 65, right? And let's just say that we think they're potentially good upper airway stimulation patients, but we have to do something to either reduce the AHI severity, we have to do something to change the collapse pattern. And the question is, well, how do they do versus folks who could go straight to upper airway stimulation, right? So when we started the study that time, we know that upper airway stim works well for the right patient. We know that MMA remains the most effective skeletal surgery, and we know that palatopharyngoplasty can reverse complete concentric collapse of the velum. So if we had to do some procedures to make the patient eligible for upper airway stimulation, does that change our results? Is it better, worse, the outcome? And because if it works well, right, then you really have upper airway stimulation and MMA surgery as things that you can sequence. And by the way, they're also both very unique. I say they actually have more similarities than differences in some ways because they're both extrapharyngeal surgery, meaning whatever you're doing with these two, you're not directly doing something to the airway muscles themselves, right? Versus, tongue-based reduction or uvulopalaryngoplasty when you're really actually mucking, on the airway muscles themselves. So these are the groups, right? This is the upper airway stimulation only group, and this is the multi-level surgical group. And when we say multi-level, they either had UPPP, dome, maxillary expansion, MMA, GGA, etc. Okay. No real differences in demographically. I mean, slightly heavier, maybe in group one, which is the multi-level to upper airway stim, but not too significant. And their age, of course, a little bit higher because a bunch of them, right, were the age above 65 outside the range situation. So this is the deal. So for example, this patient here, you can see the hardware from the MMA, the GGA, and then the hardware from hypoglossal nerve stimulation. Okay, so Both worked, of course. I mean, again, upper airway stim fairly predictable in its efficacy. Again, if it's a voltage that the patients can accept, this is group one and group two. Amplitude's about the same. The change, the decrease in AHI, very, very comparable, very, very good. Um, the multi-level slightly better. But the key thing to note here that I think is quite interesting is in terms of symptoms. The multi-level group had, more of a response when it comes to Epworth fatigue scale. And so, beyond the AHI reduction, at least symptomatically and per patient report, the multi-level groups actually did slightly better. Okay. So, patients initially ineligible now, let's say at that time, due to AHI above 65, although you can use that, right, as your guide too. If you have a patient with an AHI of 70, you can really consider, like, is this a potential patient where you do multi-level surgery, then upper airway stim may be, even better. Right. And then concentric collapse, that's all reversible. Oops, sorry. And have the two procedures work in sequence. Um, Now I'll share an interesting insight. Now coming back to, okay, the response of the tongue itself. One of my former fellows, Dr. Fleury, now at Case Western, did a very interesting study where, there are times when he notes that the tongue activates, but instead of pulling forward and opening up, during activation, the tongue actually pulls back and closes the airway. And so, of course, and he's saying that during activation, the tongue may have, different responses. Um, it's not, even though you do everything correctly, it doesn't always just protrude and open up the airway. But this led me, though, to think about an interesting concept that we have known for a long, long time. So here I'll digress for maybe just 3 slides or so. I hope we're in agreement that there are two routes to breathing, nasal versus mouth, right? Both are okay. I mean, both happen. And then if we can agree that when we talk about breathing, we're talking about breathing during wakefulness and sleep. And of course, that, there are problems when there are significant issues with sleep breathing. We really like nasal breathing. Nice study from my colleague in Japan, Dr. Suzuki, just looking at PSGs and noting respiratory arousals with oral breathing, with mouth breathing. Nasal breathing activates the dilator muscles of the upper airway. Mouth breathing doesn't. So again, we like that in many, many different ways. But when it comes to sleep breathing, there's an interesting phenotype that we have to reckon with. And this is where we did our initial study talking about the upper airway nasal complex, the nasal maxillary complex. And what we reported was that for patients with a narrow maxilla, especially at the internal nasal valve area, and in general, they're 6 millimeters more narrow than the group that responded well to nasal surgery. That these folks, septoplasty, TURB reduction, spreader grafts is not as effective. And that led to the original concept that we started doing this in 2015 with Christian Guilleminault and Audrey Yoon, where we try to convert the high arch palate, right, to the dome-shaped palate, which, by the way, the dome name came about because for about a year, that's what we told patients that with maxillary expansion, we're trying to convert their palate from a high arch shape to a dome-shaped palate. And the key is this, though. See, if the tongue, and that's what that orange thing is, okay, that's the extent of my art capabilities. But if the tongue doesn't fit inside the mouth, you know, patient's going to mouth breathe and, we're not going to do very, very well, right? So again, dome as a concept, and I mentioned the concept because there are so many different ways now of achieving that surgically, non-surgically, skeletal expansion, hybrid expansion. There's so many, but I think everything kind of describes the tool. But the dome concept, I think, is key. right? And so, and the idea is to optimize nasal breathing and pharyngeal stability, especially during sleep. So if you look at upper airway stimulation, you're asking the tongue to do that. Okay, you're asking the tongue to pull forward and curl. I hope that you think that it would do better if the tongue can fit inside the mouth, and because that's what we have seen with everything else. And I'll show you a cool case here. This is a gentleman age 40s, AHI in the 40s, really wanted to use upper airway stimulation to treat his sleep apnea, and but he was struggling with it a little bit, and I told him I would only do it if he allows me to expand his palate. He's already had 2 nasal surgeries, still feels nasal obstruction. Anyway, so we did, and this is him under sleep endoscopy. And you'll note that when he has his mouth open and with 1.8 volts, that's not really doing a whole heck of a lot, is it? Right? It's not very, very impressive. We close his mouth, and again, this is after he's been expanded, so at least we're giving him a fighting chance. What you'll notice, oh, right, at 1.6 volts, this is looking pretty darn good. So good so that it's looking a little bit violent. We dial it down to 1.4 volts. And now look at that. That's working very well. Okay. So the idea is, if you cannot achieve nasal breathing, at least to some extent, it doesn't matter how expensive or how new the interventions are, it's not going to work very well. But then again, I hope that makes sense because that is consistent with what we have learned physiologically about sleep disorder breathing. Okay. So let me close with a another cool case to demonstrate all of the concepts and the small publications that I've shared with you. This is a 45-year-old patient, BMI of 30, very, very sleepy, very much nasally obstructed. Those are his meds, and that's his PSG score. Real severe, ready to rock. I think we did, septoplasty first to see if he could tolerate CPAP. Then we had him on oral appliance, no go. Let's say he elected for upper airway stimulation first. Says, look at his so no concentric collapse of the velum, right? In fact, he had pure lateral pharyngeal wall collapse. Now you'll say, well, Stanley, you've published several times that when you have lateral pharyngeal wall collapse, your best go-to is CPAP and MMA. And sure, that's true. But remember, this is the patient's choice, right? And he doesn't want MMA, right? So there he is. I do want to show you that during his sleep endoscopy. You see how much better it is. And all I did was to close his chin and basically give him a fake counterclockwise rotation. I gave him a little fake MMA on the table, and you can see how stable that is. So technically speaking, he'd be a hell of a MMA candidate. Okay. But anyway, he doesn't want it. So, and that's okay. We put the hypoglossal nerve stim. And no matter how our poor techs try to manage the volt settings, we could never get it much better. And this AHI never got any better than 35. Previously with oral appliance, the AHI is 32. So something's not working, right? Whatever it is, something's not working, both for oral appliance and hypoglossal nerve stim. Okay. So, but, he got at least some symptomatic relief, enough so that he sees value in further treatment. And then he decided to go for the MMA afterwards. Now, before he went for the MMA, I just wanted to see, troubleshoot the hypoglossal nerve stimulator and see what might be going on. And you see here that during activation, you see what happens is the epiglottis gets pushed back and gets slammed into the posterior pharyngeal wall. This is a bit like what that Dr. Fleury study that I showed you, where you see you might be seeing like paradoxical backwards movement of the tongue. But quite frankly, it probably is just the fact that there's no room inside the mouth. So every time you stimulate the tongue hits some kind of part of the jawbone and it falls back. Okay. And same thing while that's going on with the thing turned on, I do a fake MMA, right? Just a chin rotation on the table and look at that. Right. So I feel pretty good at this stage. I think, we're ready to go. And so here he is. No, not a huge MMA per se, but got him a good advancement. And And here he is. That's the lead prior to surgery. And there he is. Okay. So, and you can argue from the get-go that, he probably is a good MMA candidate. Oops, sorry. But again, right, patient makes a decision, makes a choice. This is him after the MMA. This is the incision from the hypoglossal. And then if you would take a look at his post-operative DISE, so this is his pre-op and this is his post-op, right? So post-op without hypoglossal. Okay, so that's just post-op. 6 weeks post-op. I'm bringing back to remove some wires, not to wire them shut, like wires to, the tricks of the trade, Bob Riley stuff. Anyways, so I get a chance, and that's only at 6 weeks, and it's already very, very good. And over time, that lateral pharyngeal wall is going to dilate some more, and then we can always turn back on the hypoglossal whenever needed. Okay. Um, so in closing, again, nothing's going to beat a comprehensive airway evaluation, and it doesn't all have to happen in the beginning, meaning you could be troubleshooting things along the way, or patient, first wants DISE, first wants upper airway stim and then MMA, and you just have to do that complete evaluation, across different time points, okay? Ineligibility is often modifiable, and we've shown that not only with UPPP surgery, but it's modifiable with DOME, MMA. It's just all on that pathway, right? It's all on the continuum. Especially if you're a surgeon who can offer all of those options in the same clinic, in the same team, then you are just, carefully, methodically walking the patients towards a happy place. Multi-level sequencing does improve outcomes. So we've known that repeatedly. We've just known that repeatedly. Anytime you do a multi-level thing, in comparison to any single level intervention, the multi-level is always better, right? And then really, at the end of the day, the skeletal framework, whether it's maxillary width or whether it's maxillomandibular, projection, the position, that really sets the ceiling for everything else we do, including upper airway stimulation. All right. So I hope I've shown you some interesting literature and cases that is, a little bit different and extra than just upper airway stimulation. And like I said, I welcome your feedback, and I do hope to see you guys in person soon. Thank you.